like to thank the organizers for inviting me here to tell about the contribution of nuclear medicine in neuroendocrine tumor patients. And these are my disclosures. It's very important to realize that in 2016, nuclear medicine is by definition now a hybrid imaging specialization. We've had PET CTs for a long time, and in more recent years, we've had SPECT CTs, and now more recently PET MRs to our disposition. And the role of the nuclear medicine physician is to highlight molecular targets on top of the morphological images. Now, neuroendocrine tumors are a tumor type for which many different targets have been explored and tracers have been developed. And broadly speaking, we can divide these in two categories, either peptide receptor-based tracers or tracers that look at the broad metabolism of tumors, both the intrinsic metabolism and also the fact that these tumors, by definition, produce hormones. So I will spend most of my talk on somatostatin receptor imaging and on FDG-PET because it still has a role. Now, in nuclear medicine, when we develop radiopharmaceuticals, we typically have a vector molecule, which is the part of the radiopharmaceutical which is going to interact with the target. We have a linker to attach or not a radionuclide, and then finally the radionuclide, which will emit upon decay a signal that can be detected by our cameras. Now, in the case of peptide receptors, we have receptors like bombesin receptor, CCK receptor, VIP receptor that have all been explored, but by far the gold standard in the NET field is the somatostatin receptor, which is a 7-transmembrane G-coupled receptor. There are 6 human subtypes from 1 to 5 and 2A and 2B, and the function of this receptor is to diminish secretions, both endocrine and exocrine, to diminish cell growth, and to increase apoptosis. And it's also internalizing upon binding with an agonist. This is a data set of 34 neuroendocrine tumor patients, and we see stainings for the different somatostatin receptor subtypes. And you can see that it's mainly 2A and 3 which are positive in more than 85% of patients. And 2A is also membrane bound, so making it an ideal target for radiopharmaceutical detection. Now, the somatostatin receptor is overexpressed in all the typical NETs, carcinoids, pancreatic NETs, but also in other tumor entities. This is important to remember, such as, for instance, meningiomas, but also renal cell carcinoma, GIST, and tumors of the neural crest. So it's not specific for neuroendocrine tumors. The overexpression of the SSR correlates with differentiation status. It doesn't correlate with hormonal function, and it is a target, of course, for pharmacological treatment or radionuclide therapy, as we heard from the NETTER-1 trial. Over the years, different agents have been developed to image this receptor with different vector molecules, different chelators, different radionuclides, and the ones that are currently in use are indium-111 DTPA octreotide, also called pentatriotide, which can be imaged by planar imaging or SPECT. And then we have gallium-68 GA-DOTATATE, and GA-NOC, which are imaged with PET. These are derived from an 8 amino acid version of somatostatin, which is octreotide. And by changing specific amino acids, for instance, changing phenyl to a tyrosine, we get TOC. If we change it in octreotate, we get TATE. And if we put an artificial amino acid, naphthalene, now we get NOC. And it is then labeled with gallium-68. Gallium-68 is a metal, so we need a chelator. It is coming from a generator. One generator can last up for 1 year, and you do not need a cyclotron on site to produce this radioisotope, and so you can use it in non-cyclotron centers. This is a normal biodistribution of gallium-68 DOTATOC. We see high uptake in the pituitary gland, in the adrenals, in the spleen. We see moderate uptake in the liver, and we see excretion to the urinary system. And we have low uptake in lung, brain, and muscle. So here we see the pituitary gland, which is like a cyclope, uptake in salivary glands, in thyroid. We see moderate uptake in the liver. Highest uptake in normal patients is within the spleen. Excretion through the kidney, some diffuse uptake in the bowel loops can be seen, and finally both adrenals will also show high uptake. Now, it's very important to realize that the accumulation of these radiopharmaceuticals can be very high. This is one example. We see the patient on the left. You almost do not see the normal contours of the patient anymore. And you see that this patient, it's a MEN1 patient, has 3 neuroendocrine tumors in the pancreatic tail, showing very intense uptake. And this is a feature that allows to detect very small lesions by using gallium-68 labeled PET. This is another patient which has retroperitoneal lymph node involvement and also a liver metastases, which are shown here. These lesions have very high SUV values, 35 on the lymph node, but it also has supraclavicular involvement. And if you look at those sites, we see that we have partial volume effect, so the SUV is lower, but we see a very tiny lymph node of 4 millimeter, which is actually a pathological node at this site. And the second site, its bifocal uptake, is a lymph node of 7 millimeters, but which is certainly not pathological for radiological criteria. Here another example, we see a patient with a solitary bone mat in the left ileal wing, and this is also not picked up by CT. Now, the contribution of somatostatin receptor radionuclide imaging is that it's a sensitive and specific detection of tumoral lesions, including very small lesions in grade 1 and grade 2. It can help to make the diagnosis of NET in cases of clinical suspicion based on morphological imaging, hormonal symptoms, or elevated chromogranin A. And it is useful in pre-op, post-op staging, suspicion of recurrence, and in advanced therapy planning. But it can also be useful to perform molecular characterization of the lesions, and so it is actually a predictive biomarker for somatostatin analog treatment and for PRRT. So it is included in the ESMO guidelines, and it is part of standard care. And the data actually to support this, or part of this, are shown here. This is a comparison of 3 tracers, pentyreotide, FDG, and MIBG, and we see that the somatostatin receptor imaging shows more lesions than FDG and certainly more than MIBG. This was seen in all different subtypes of tumor except for colon, but there were only very few patients. So I have a total sensitivity of 89% compared to lower than 60 for the 2 other tracers. And if you then break this down according to the Ki-67, I think this is very interesting data, you see that in the group below 2% and from 2% to 15, somatostatin receptor imaging outperforms FDG with higher sensitivity, but in the group above 15%, then you have a 92% sensitivity for FDG and only 69% for somatostatin receptor imaging. And also bear in mind that in the grade 1 group, 41 of the patients are still positive on FDG, and I will come back to this later. Now, somatostatin receptor imaging can be semi-quantitated. We typically use the Krenning scale with grade 1 less than liver, grade 2 equal to liver uptake, grade 3 is more than liver, grade 4 is most intense uptake in the tumor. And I mentioned that somatostatin receptor is a biomarker for tumor treatment. Well, these are the 2 main treatments showing PFS with cold somatostatin analogs, the PROMET and the CLARINET trial that you all know quite well. But it's important to realize that these patients had all had somatostatin receptor scintigraphy. In the PROMET, this was in 86% of the patient, and in 74% of total, these were positive. Negative scans were seen in 12% of the total population, and in 14% it was not performed. So this is a group with a high positivity for somatostatin receptor scintigraphy. And the CLARINET is much clearer. It was an inclusion criterion. Patients needed to be Krenning grade 2. So I think that a lot of the data for cold somatostatin analogs is actually referring to patients that are positive on scintigraphy. We just heard the NETTER-1 trial data. I just want to remind that patients needed to be positive on all lesions with a grade 2, according to Krenning at least. Now, somatostatin receptor scintigraphy is the best nuclear medicine technique that we have in grade 1 and grade 2, but what is the best radiotracer to use? Since 2007, there have been data that are consistently showing that peptides labeled with gallium have a much higher sensitivity than the indium-labeled pentyreotide. First series showed 97% sensitivity compared to 52% for the conventional indium-11-based molecule. In the same year, a smaller study showed 100% versus 66%. And in the last year, 3 studies have added to the data. And in 424 patients in total, if you look at the range of sensitivity for indium-111, it goes from 12 to 72%. For gallium-68 peptides, it goes from 74 to 100%. And so the difference in sensitivity, because all patients had both scans in this table, it goes from 24 to 64%. So I think the debate is closed. The gallium-68 peptide PETs are outperforming. And this is just one example. You see a patient that has one liver met on planar imaging, and on just one single slice of the gallium-68 DOTATATE, you see that there are already 7 liver metastases present. Now that's an unfair comparison because you're comparing tomographic versus planar data. So we looked at the PETs and we looked at the SPECT data, and in the blue arrow marks a lesion which is visible in both, although much clearer on the PET data set. But the red arrow now is pointing to a lesion that's only visible in the gallium-68 PET. So this type of lesion we call this an incremental PET lesion. And you see that incremental PET lesions are, on average, 40% of all the lesions. You only see them on the PET. And in 75% of the patients, 20 to 100% of the lesions are missed by indium pentynucleotide SPECT, which is the best you can do with this molecule. And this is perfectly in line with data of the recent American study which has been published. It's the largest series on the record, 131 patients. Gallium DOTATATE in this case has a sensitivity of 95%, indium pentynucleotide 30.9%, CT only 45% as well. And this resulted in change in management in 43 out of 131 patients, so that's almost 1 patient out of 3. And in patients that had carcinoid symptoms that were negative on biochemical testing, gallium DOTATATE was positive in 65%, and 40% of those positives were only seen by gallium DOTATATE. So I think this shows the great value. Now, DOTATOC, DOTATATE, DOTANOC, which one is the best to use? Well, there it's actually quite easy. They have different affinity profiles, but the clinical end result is the same. They will pick up the same lesions. And you see a TOC versus TATE comparison. TATE picks up 97% of the lesions. The image looks the same. And this is a NOC versus TATE comparison. And you typically get these images where both scans actually show the same lesions with roughly the same intensity. And here you see that NOC picked up 89% of the lesions of TATE, and the difference was all due to one single patient. So if we start using gallium-68 DOTATATE, as we now should, we will detect smaller lesions. We will detect lesions that only show light to moderate somatostatin receptor expression. The detection of more lesions might or might not impact therapy, but we've just seen that in a substantial fraction of patients it will do it. We can do one-stop shop. It's only 90 minutes for gallium-68 on a single day. Indium pentynucleotide patient needs to come back to the hospital after a night. And we need to be careful by comparing the indium 111 data with gallium-68 PET because we see more lesions and it's not necessarily disease progression. Now, the next step in this field probably will come from somatostatin receptor antagonists. This is because all the data that I show now are based on agonists. Agonists bind to the activated receptor bound to GDP, cannot bind to the inactivated receptor, which is bound to GTP, whereas antagonists can bind to both the activated and the inactivated receptor. So if you use radiolabeled agonists, you can only bound to a fraction of the receptors, as most of them are in the inactivated states. Whereas if you use the antagonist, you will have much more target and much higher accumulation, and this can lead to these kind of images. This is not a difference of scanning technique. It's the same isotope, same imaging technique, but you see a tremendous amount of lesions on the right with the antagonist that are missed by the agonist. Some pitfalls. One very important pitfall is the pancreas head or uncinate process with these lesions that you can see over here. And you should be careful not to do Whipple procedure without cytological or morphological imaging confirmation based on this kind of physiological uptake. Meningiomas can be positive, so if you have lesions in the skull, beware it might not be bone mets of the NET. We see the pancreatic head again. Inflammatory lesions such as osteoarthritis can be positive, and this is an intrapancreatic spleen in a patient that also had accessory spleen. And of course, spleen tissue will take up these ligands and so will be positive on the scans. I will skip the part on the GLP-1 for time issues, and I will now move to FDG. So FDG is a sensitive detection of tumoral lesions, including small lesions in grade 3 patients. We can use it for staging, detection of recurrence, restaging, and therapy monitoring, but also for molecular characterization of tumoral lesions. It is a prognostic biomarker, and it can guide for biopsy or re-biopsy in case of clinical or morphological progression. And this is very interesting data. It's from the Danish study that I already previously mentioned, but you see that there's a huge difference in PFS between patients that are FDG negative compared to FDG positive with a hazard ratio of 9.4. And there's also a similar hazard ratio for FDG negative versus positive for overall survival, showing that FDG positive disease clearly has a worse prognosis. This is an example of a metastatic patient, clearly positive on DOTATATE, negative on FDG. This is a patient positive on FDG and positive on DOTATATE and also positive after treatment. And in the PRRT field, it has been recognized that FDG positive patients have prognosis which is less good than FDG negative ones. And in this data set, specific in the grade 2, the PET positives had 32% progressive disease, and PET negatives had 0%. Of course, these are small numbers, and I think this is certainly an area of interest for further studies. And the group of Samer Ezidin in Bonn has taken this one step further, and they have proposed a metabolic grading system of NET by looking at the FDG uptake and looking at the tumor to normal liver ratio. If the ratio is less than 1, it's a metabolic grade 1. If it is above 2.3, it's a metabolic grade 3, and in between it's metabolic grade 2. We see here 3 examples of patients. Metabolic grade 1, we don't see any uptake in the liver metastasis. Metabolic grade 2, we see some faint uptake in the liver met at the dorsal part of the liver. And metabolic grade 3, this looks like a highly FDG avid tumor with liver mets all over the liver. And these are the survival curves based on the metabolic grading that we see on the right, and we in particular see that the metabolic grade 1 has a very good prognosis, which is actually better than the prognosis coming from the Ki-67 based pathological grading. I will not go into details about a very interesting topic, but the fact that neuroendocrine tumors have expression of the LAT amino acid transporter, they can take up precursors of hormone production. F18-DOPA, carbon-11, 5-hydroxytryptamine have been developed and can be of use. Now, these are only limited amounts available throughout Europe and not in the United States. And so, yes, I will finish up. So, and I will also not mention these. And so I would like to summarize so that somatostatin receptor scintigraphy has a high sensitivity compared to conventional techniques. It's part of standard management. It's the first choice in grade 1 to 2 NET. Indium pentiotride is not the gold standard anymore. Gallium-68 DOTATATE PET are the best tracers and should be used. And FDG is the first choice in grade 3 NETs. It offers prognostic information in patients with grade 1 or 2 NET. And maybe we could evolve to a metabolic grading system in metastatic patients. Thank you very much.